First of all, I would like to thank the organizers of the PodCon for giving me the chance. And I think we are already running short of time, so I will just rush through my panel discussion. I will show a few cases. So who are the panelists? Let me know the panelists. Okay, no problem. So this is case number 1. There is a fracture. A 32-year-old male with a history of alleged RTA presenting with a shoulder pain right. Now, Dr. Raju, what is your diagnosis and...
Do you have any other views, sir?
No, sorry.
That's a displaced proximal humerus fracture, and I suspect there is a GT fracture as well. It is. I need more views to come as.
Unfortunately, I don't have more views.
Sir, do you have CT?
No CTs. Dr. Sibyl, what would you like to do? How will you proceed?
So what is the age of the patient?
He's a 42-year-old.
So definitely the displaced fracture. I need, as was discussed, I need lateral views and CT to rule out if there is any intra-articular component extension.
CT, suppose we take that CT is
there is no intra-articular.
No intra-articular fragment. How will you proceed?
Plan for fixation.
Dr. Ali, what fixation do you?
Ideal for a nail fixation. If we have to see whether that's a GT. If there is GT, it can do localization sutures or into that. But it is very good for a nailing procedure.
Any difference of opinion?
Before that, clinically we have to assess the neurovascular status, everything.
And that's okay, no problem.
So the fixation, that mode of implant is absolutely the surgeon choice. I think for me it is a Philos fixation because I am comfortable with that. Moreover, I can visualize the rotator cuff. So along with, if there is any rotator cuff injury, I can repair it. So Philos is, I think that is good in my hand.
Dr. Sibyl, which implant will you want?
I will also go with Philos.
So there is only one person to take the your nail. Okay, this is what we have done. Now comment upon the fixation.
There is translation.
The medial calcar continuity is not there.
Are you happy with this fixation?
No.
Not happy.
No, not happy. What is wrong with this fixation?
So the post-operative assessment is based on the position of the plate number 1. For that you have to draw a line through the long axis of humerus and perpendicular through the tip of the plate and another one through the top of the humeral head. And this case the vertical position is fine because that is not crossing above the head of humerus. Otherwise it can produce impingement. And regarding the fixation, I am worried about 2-3 things. One, the calcar screw. And the reduction, is it in varus, I believe? Then the distal screws are a bit longer.
There is a translation of the upper fragment from the shaft, which is more than around 5 millimeters.
So,
the lateral view of the same picture. Lateral view.
The lateral view is there. You can see that.
The calcar screw is not in the correct position. It looks like a varus reduction.
It's a negative reduction. Negative reduction. And one screw is just beneath the subarachnoid.
Given a chance, whether you will accept a varus position or valgus position, if there is a malunion.
Valgus.
Definitely valgus, but not more than 20 degrees.
Okay. So this position is not at all acceptable.
Yes.
Okay. Now this is my case number 2. Yes.
It's a fresh case or a old? It's a fresh injury.
Another case. Middle-aged man.
Any other view?
No. No CTs? You have to forgive.
So there is no medial calcar continuity, like
Okay.
when going to varus, definitely
Okay.
needs fixation.
You want a fixation.
Fixation.
Which implant will you opt?
You need a graft, stud graft also along with fixation. in this
Sometimes
case.
I think because
Because
the head
the
is
medial-
rotated, you can't say there is the medial
Yeah.
calcar is there. I think the head is
But
rotated.
it is tilted off.
So I think
But it is.
I will go for plate only. Philos
It's plate. You can support with a fibula stud graft if you want.
So the important thing is the medial calcar. If the medial calcar is there, that's well and good. The chance of AV is less. So fortunately, the medial calcar is there. So we need an absolute anatomical reduction and stabilization. Philos would be good so that you can start early mobilization.
Dr. Nitin, which approach will you take?
So it's a displaced 4-part fracture. So
Yeah.
preferably we'll go deltopectoral approach so that you can intra-articular reductions would visualized. And use a Philos plate.
So all of you opt for Philos plate. Okay. Now this is what we have done, and comment upon the fixation.
Medial
That one
cortical.
fragment is displaced, and during the surgery we would like to know the subscap. Was it avulsed or not? If it was avulsed, you have to correct it. That fragment is a pathognomonic for some avulsion kind of thing.
Definitely, subscapula may be avulsed.
You might have repaired it during the surgery.
That's it.
Medial hinge is broken, so preferably as signs are told, you would have done a fibular strut.
Okay. I think the calcar screw can hold, isn't it?
But there's no continuity of the medial cortex.
Okay. So all the panels are not happy with the fixation, right? Okay. This is the third case. What will you do? What is your diagnosis and what will you do?
3-part nears, 3-part fracture.
Okay.
And the GT is proximally migrated. You can appreciate it is above the head.
Hmm.
So during fixation, it is in varus. You have to get a perfect anatomical reduction and distalization of the GT. And you can very well fix with a Philos plate.
So this is the fixation. Comment upon the fixation.
That is not anatomical. It is again in varus position. Number of screws on the proximal is okay. And what is the reason why in between you have omitted certain screws?
Lateral has to be seen.
Regarding the length of the plate, has not utilized all the holes.
Why you want this?
Maybe the plate is too long.
Yeah, why do you want to this much of
So the surgeon
an
opted for little metal work.
So we the panelists are worried about what biomechanical advantage such a long plate is providing.
No, long incision,
Yeah.
long plate.
Yeah.
If it was a biological fixation, it was okay. But otherwise,
Otherwise, they should have put all the screws. All the holes should be screws.
you don't need that much of hold in the shaft for this fracture.
You could have used a shorter plate, and if you are not using the distal screw, the chance of stress riser is high for the distal most screw. You could have used either a unicortical or a bicortical.
Nitin, any comment?
So the screws are all long,
Longer
and
screws.
you should have put at least 3 to 5 millimeter shorter than the measured length.
Sir,
So
another
if it
thing
goes
is-
into varus, it will go into the joint. So screw penetration chance is high.
And the position of the GT is much higher. So in such fixation, needs a 3-part or 4-part fixation, the first and foremost is reduction of the GT. First, we have to manage the GT by neutralization screw and fix it with either with a temporary KYS or neutralization sutures. Then only you proceed with the Philos. That is a basic principle. Here you can appreciate the GT is far above the head of the humerus, so there is high possibility for impingement. Patient may not be able to do this.
Would you like to do it in a deltoid splitting approach or a deltopectoral?
No, deltopectoral you can rotate the humerus arm and you can visualize it because the the direction of our rotator muscle is from the posterior to anterior. So GT is a bit anterior. So there is no problem in exposing deltopectoral.
Okay. Any other comments?
You can go through the
No?
You can depend on the surgeon's choice. You can go for deltopectoral or anterolateral deltoid splitting approach. So one or two, three things. One, the reduction is in varus. Secondly, head screws are longer. Thirdly, GT is not well positioned. Fourthly, it's a longer plate. You don't need this much of the plate.
Okay. Now this is the fourth case. Results are restored.
Next spot call.
Yes. Rajanish. Say 20 years. No, this is 58 years. It's a osteoporotic fracture. Yes.
That GT seems to be intact. Maybe a two-part, I don't know. And if it is intact, a philos would be good. Otherwise, as Rajanish pointed out, you can proceed with a replacement. But here it is a two-part, and there is osteoporosis, and the quality of the bone is not at par with the age group of that patient. So we have to investigate whether the patient is having diabetes or some rheumatoid arthritis or
No such comorbidities.
But this much osteoporosis
That is right.
is a male patient.
It
This
is
much
a
osteoporosis.
male patient.
Osteoporosis for this age is something unusual. So philos would be good so that you can start early mobilization. Since GT is intact, if it is intact, rotator cuff is also intact.
It is a severe varus, so you have to reduce it. Then you can find out.
Definitely needs fixation.
Okay. This is what we have done.
X-fix.
What is your comment?
Reduction looks okay.
The reduction is so good in this view.
See, this reduction was done under Siam and percutaneous fixation with the external fixation. That's an external fixation. Actually, this was done as a thesis for one of my postgraduates.
And only thing is,
Actually, no.
it's a
Actually.
Sir, there is no harm in doing this. There are different ways, external fixation, internal fixation. All the textbook says for the four-part fracture, multiple pinning and early mobilization. But this is the era of biomechanical, because the union is a race between the biology and the biomechanics. So if you are providing a good stability in by internal fixation, you can start the mobilization. These are smooth pins, so chances of loosening and when you are mobilizing, there is the only problem.
No, these are, I think it is a threaded pin.
Still, there is a chance you have to keep it at least for a period of 6 to 8 weeks. There is a chance for pins. I'm criticizing the X-ray only, not the surgeon. But in this era, we have enough gadgets. So, internal fixation would be much better than external. That's what my view.
Okay.
All the pins were unicortical also.
Pardon?
All the pins were unicortical, so there's high chance that it can bend and fail. Unicortical pins.
No problem. But there are multiple pins, isn't it? That adds to the stability.
Is it engaged into the opposite cortex? That is what. Is it engaged into the opposite cortex?
That's also there. There are 4 pins that adds to the stability, isn't it? So
Main issue would be pin loosening, right? Because when you start mobilizing the pin track, because it's going through so much muscle mass, so the chance of pin loosening is otherwise this reduction looks good.
now I showed this X-ray to highlight the point that there is also other options for proximal venous fractures, especially in
Two-part.
two-part fractures.
That's all. If
Especially
it is
in very old age patients. Well, you can use the threaded pin, that is useful.
There is only one indication for me for this fixation. If my anesthetist is so adamant that you should finish the surgery in 2 minutes,
Definitely.
then I will go for this.
In our setup, that is
Sometimes there is a multiple comorbidities and we can't accept that much deformity.
at least I think you should keep this in mind. That's all. Now this is the fourth case. It's a 4-part fracture. Yes. If you have a very good eye, you don't need a CT, isn't it?
How old is the patient, sir?
We don't have a 3D eye.
Definitely.
Age of the patient, sir.
This is I think 50s to 60s. There is a subluxation also.
CT is mandatory before proceeding this.
Definitely.
If it is fixable, better we go for anatomical reduction and fixation. If it is badly comminuted, if there is any head splitting and all, go for a replacement surgery and reconstruction of the rotator cuff.
Okay. So this is what we have done.
Plate too high.
Too high.
In this view, they are like
Criticizing the X-ray, the position of the plate, it is
high.
high position. It is above the head. So impingement is a problem and pain, that will result in pain.
Looks anterior.
So the treatment, the dictum for plate placement is GT should be below the head, plate should be below the GT. 5-5. So topmost will be the head, then GT, then plate. Here it is, plate is on the top. So definitely abduction will be restricted. The view is an oblique view, we can't comment.
Oblique view. We don't know.
And this is a result.
Yes. Same patient.
Same patient.
He is lucky enough to have this moment, even though the position of the plate is not acceptable.
Same patient. No, not important.
I will need to have everything with you.
Okay, all these theoretical points, when it comes to the practical things, sometimes you may be mistaken. Understand? So, I also surprised to see this much of result for this patient.
Shoulder is a forgiving, joint because there is a scapulothoracic movement as well. 90% of abduction is happening in the glenohumeral remaining. So this abduction that will be happening from the scapulothoracic.
I will show a few more slides. Yeah.
It's a head splitting fracture, looks like a head splitting fracture. So CT is advisable.
Yeah, CT is there.
Yeah.
At last. At last.
At last, 2024.
What is the age of the patient, sir?
58.
So keep both the options. You can plan for fixation. If not possible, you can go for hemi replacement. But the hemi should be always on the back table before you plan. Aim for fixation, Philos plating, because it's only 58. 57 or 67.
Another option is just unique.
Just unique.
Just unique.
So you go for a fixation.
Yeah, my primary main is to just fix.
This
Reconstruct the
is
GT.
in the CT you can see that it is a severely comminuted fracture.
Yeah, but you can get reduction if possible. You aim for reduction, fixation. If it is not possible, then only you go for replacement. Replacement is not the primary indication for me. That's my treatment option.
Okay, this is what
Yeah.
been done.
So nearest prosthesis.
Sir, have you reconstructed the rotator cuff?
Now you see the X-ray.
Pardon, sir?
See the X-ray. See the date of the X-ray.
2024.
2024.
Which
Thing is that if the
which institution it is done?
but you are present, that's what.
That's okay. I think Dr. Nitin
But
may
the thing is
be
that one point I would like to highlight is
okay. Yes.
unless otherwise you reconstruct the rotator cuff, most of the beginners, they put the implant and close the wound. Unless you reconstruct the rotator cuff, the head acromial space will be reduced. Rotator cuff is a depressor, it should be there. Otherwise the functional results will be poor. The active movement and there will be pain and erosion of the...
Even otherwise, the heavy arthroplasty of the shoulder is a, I think,
Palliative surgery.
yeah, palliative surgery. Doesn't serve much purpose. Ideally, this patient should have a.
Reverse shoulder would be much better than this.
Understand. Yes.
It also looks
From Malapam. That is why the X-ray looks like a green, huh?
So that looks like a 4-part fracture.
Okay.
A 4-part fracture. So proceed with the fixation.
You prefer.
So, before every surgery,
definitely.
juxta-articular we need a CT scan since we don't have CT scan. Juxta-articular fixation. First you stabilize the greater tuberosity.
Okay.
And we have to fix the lesser tuberosity as well. The calcar is also broken, so we have to address all this.
This is what we have done. Now, what precaution, Dr. Jipin? Okay. Now, when you are doing a deltoid splitting approach for a proximal humerus, how will you do? How will you put the incision?
The most important thing is the axonal nerve. So 5 centimeter, usually below the acromion process is the axonal nerve. You have to be careful to address the axonal nerve. That's the most important thing.
Would you like to see it and retract it, or would you like to avoid that?
It's personal choice of the surgeon. For me, I never see the nerve.
So you put as 2 incisions.
2 incisions.
So that is a better option.
Yeah. But some surgeons prefer to see the nerve and retract it. It's personal choice.
Any other
2 incision. This is a continuous incision.
2 incision or continuous?
2 incision. This is a continuous incision.
Okay.
I used to see the nerve and do.
So you can see the nerve and go, or you can feel the nerve with the tautness. You can feel the nerve and slide the plate beneath it. Always.
I think we don't have to feel the nerve. You put an incision above, put an incision below, just try the plate and fix it. That's okay, no problem. What happens is, whenever you try to find or when to try to see the nerve, usually that patient ends up in a neuropathy.
Yes, I always do.
See, that is the follow-up X-ray. Now, comment upon the X-ray. This is a follow-up X-ray. What happened? Any postgraduates here?
It looks.
Postgraduates?
Mubashir.
Yeah, Dr. Mopashir. This is a, yeah, you stand up. No problem. You see, you look at the X-ray, and this is a proximal humerus fracture fixed by a Philos plate, and some complication has occurred. What is the complication? No, what exactly is the complication there? Avian. So this X-ray shows the avascular necrosis of the humerus head. Understand? So how will you manage this?
There is a GT version, no? That fragment, I think, is the
That
GT.
is there, but I wanted to show this film.
Is there avian? head
Yes,
lesson?
definitely.
Reverse shoulder.
Can go for reverse shoulder.
There doesn't look like avian, no?
Yes, there is avian.
The GT version is good.
What will you do in this case?
Philos. Age of the patient?
27.
Fix it. Philos plating.
Okay. What will you do in this case? I think Anine will be tempted to. Right.
Nail it.
Nailing. Okay.
Nail it and rotate it up prepare. But there are light equations to that.
There is, you have to see that the quality of the bone,
On the second X-ray, on the side X-ray, there's light,
right side X-ray,
light equations.
looks pathological.
Yes, I will finish it off. Now, this is for Rajanish.
fracture is there,
It is a floating shoulder. So what will you do?
you fix the clavicle,
You fix the clavicle first, then
fix the humerus. Fix the
will you fix the scapula or will you leave it alone?
I may leave it alone.
Because it is a subglenoid, isn't it? The glenoid is intact, so you don't have to fix the.
Polar ankle is intact.
Okay, so
There's no
that's
medialization.
yeah. So this is what the surgeon has done. Fixed the clavicle.
But there was a fracture in the humerus, right?
Ah, there is a fracture also in the humerus.
Shaft of the humerus, nothing has been done for that. The other X-ray, the one X-ray back, there is a sharp fracture.
Yeah.
And then there is a sharp fracture.
Haven't they fixed the humerus in the next X-ray?
No humerus fixation. Oh, this is another X-ray, sir. Pre-op and
Yes.
post-op.
You can
Not
see.
this one, not this one. Nail
Okay.
it.
What will you do?
Nail it. Biopsy, nail
Looks
it.
like a pathological.
Okay, thank you. Thank you for the
Thank you.
participation.
Thank you, sir.